Good morning, ladies and gentlemen. We're going to start now. Ladies and gentlemen, it is my honor to introduce Prof. Laurie Loevner, a distinguished neuroradiologist and educator. She is Chief of Neuroradiology at University of Pennsylvania, and she has led the major radiology societies with over 170 publications and multiple textbooks, with numerous awards. She is pioneer in MRI research and dedicated mentor. Please join me in welcoming Prof. Loevner.
Good morning, everybody. We need the microphone. Can you hear me? Okay, wonderful. Well, good morning, everybody, and I'm grateful to have this on-time start, really wonderful. I'm delighted to speak to you today about the extramucosal spaces in the head and neck. These are all the compartments posterior to the mucosa, where we were talking about cancers yesterday. I've been asked to give a case-based kind of lecture, so I am delighted to show you a lot of pathology, all path-proven. So what we're going to focus on this morning are the submucosal spaces at and above the hyoid bone predominantly, and we are going to be looking at lesions arising primarily from these compartments. We're going to talk about the prestyloid parapharyngeal space, the masticator space, the post-styloid parapharyngeal space, which we call the carotid space, the retropharynx, and if we have time, we will move on to show a few lesions in the paravertebral compartment. So when we look at the extramucosal spaces of the head and neck, I encourage you to use a T1 weighted image. The prestyloid parapharyngeal space is one of the many fancy boots that we have in the head and neck. You'll see that it's this structure here. It contains predominantly fat, and it sits posterior to the masticator space, which has the muscles of mastication and the ascending ramus of the mandible. We have the poststyloid parapharyngeal space, or the carotid space, which has the internal jugular vein, the carotid artery, and cranial nerves. We have the retropharynx between the prevertebral muscle and the constrictor muscles, which is a potential space that has fat until you get pathology. Then you see the space well. And the paravertebral compartment has the prevertebral and the paraspinal components, and if we have time, we'll cover a few lesions there. So let's start first with the prestyloid parapharyngeal space. Again, it is in the shape of a boot. It contains predominantly fat, and it is bounded by the deep layers of the cervical fascia. The medial margin is made up of the middle layer. The lateral margin is the superficial layer of the deep cervical fascia, and the posterior margin comprises all of the layers of the deep cervical fascia. So when you're looking at all of these different spaces in the head and neck, the most important thing to do is to understand the normal structures that sit in those compartments. If you understand the compartment that you're in, first and foremost important, and you know the structures that live there, pathology arises from those structures. So each compartment has a very limited differential diagnosis of about 5 pathologies that you need to remember. So again, the most important thing is when you see a skull-base mass is to stop and get it in the right anatomic compartment. So the prestyloid parapharyngeal space has fat, it's got lymphatics, it's got the 3rd division of the trigeminal nerve, it's got external carotid artery branches, it's got the deep lobe of the parotid gland here with the asterisk, and it's got the stylomandibular tunnel, the styloid process, and you also have rest of minor salivary tissue, little bits of salivary tissue that not only go throughout the mucosa, but also sit down in the prestyloid parapharyngeal space. The differential diagnosis of pathology in this compartment, if you look at all comers, most of this represents extension of tumor or infection from an adjacent deep space. Primary pathology arising in the prestyloid parapharyngeal space most commonly is a salivary gland neoplasm, and it may come from the deep lobe of the parotid gland, or it might come from minor salivary rest. Schwannomas occur there, and adenopathy. Those are the things that you want to think about. Again, the most common pathology is spread of an abscess. So here is an abscess in the peritonsillar region. You can see it starting to spread into the fat of the ventral prestyloid peripharyngeal space. You can see the normal side for comparison. And this is a patient with a nasopharyngeal carcinoma. And you can see that the prestyloid peripharyngeal space is filled with neoplasm. This is what's most common, direct extension of pathology from the pharynx, infection, neoplasm. But today's talk is about lesions arising primarily in these locations. So primary lesions in the prestyloid peripharyngeal space, differential diagnosis, salivary gland tumor, salivary gland tumor, salivary gland tumor. And once you've decided that you're probably looking at a salivary gland tumor, you want to determine whether it's coming from the deep lobe of the gland or from minor salivary rests. The surgical approach, if they're going to be resected, is different. So if it's coming from the deep lobe and it goes into the stylomandibular tunnel, they'll take it out through an open surgical excision. But if it's coming from minor salivary rests and it's disconnected from the deep lobe, they'll take it out at our institution robotically, take it out through the mouth. So it's different. The other solid masses, schwannoma, lymphadenopathy, and then occasionally you'll get branchial cleft cysts there or mucus retention cysts. Now, the important thing about pathology arising in the prestyloid peripharyngeal space is that the vast majority of these are asymptomatic. They're lesions that are detected on brain MRIs and cervical spine MRIs and neck CTs that are being performed for completely different reasons, a headache, dizziness, and then we find these masses at the skull base. Symptoms that make me nervous, if somebody's coming in and they've got ear pain or symptoms referable to the temporal mandibular joint, ear fullness, facial pain, or facial numbness, I become very concerned, and you should check every corner of your film for involvement of cranial nerves, etc. So let's look at some primary pathology coming from the prestyloid peripharyngeal space. This is the typical benign mixed tumor or pleomorphic adenoma. You can see a large mass replacing the fat in the prestyloid peripharyngeal space. You can see that the muscles of mastication are being displaced anterolaterally. It's a circumscribed T2 hyperintense mass, and if you look very closely, you'll see the peripharyngeal fat enveloping it, encompassing it, embordering it. Very important. Okay, it's bright on T2, it's got heterogeneous enhancement. We know, statistically speaking, this is most likely a benign mixed tumor. But now we have to figure out for the surgeon, is this coming from the deep lobe of the parotid gland, or is this coming from minor salivary tissue? So if you look here, you'll see this is the deep lobe of the gland, and does everybody see the nice fat plane? So there's a fat plane separating the mass from the deep lobe. This is coming from minor salivary rest, and this can come out robotically through the mouth without having to make an excision. This is another typical benign mixed tumor, T2 hyperintense, classic. And you'll see the heterogeneous but solid enhancement. This is the unilocular benign mixed tumor in the prestyloid peripharyngeal space. And here's another benign mixed tumor in the prestyloid peripharyngeal space. And this is multilocular. You'll see multiple lobules. It's lobular. We call this the cluster of grapes. It's like holding a stem with grapes coming off. And this one is coming from the deep lobe. You can see that there's not a good plane coming between this one. So this is another benign mixed tumor. Now, this is one of those rare cases, tricky case, but this is why we often do a fine needle aspiration. I do them through the face before we take them out surgically for histologic confirmation. This is a neurologist that actually came to me from Johns Hopkins, and you'll see a circumscribed mass. It's in the prestyloid peripharyngeal space. It's T2 hyperintense, and the enhancement pattern's a little bit different than what we would see. I call this sort of the tree and bud appearance, very heterogeneous. She had been told that she had a benign mixed tumor and was coming to us for robotic consultation to have it taken out robotically. And I looked at it and I just didn't feel it was like a classic benign mixed tumor. So I biopsied. I put a needle through, I stuck a needle in, and I got back venous blood, lots of venous blood. They went to pathology, no cells. It was just blood. So then I said, well, let's get a technetium red blood cell scan. So here's your tagged RBC scan, and this is a classic venous malformation. I've been following her now for 10 years. No surgery. This is just a developmental venous malformation that she's had her whole life. This is a typical schwannoma in the prestyloid parapharyngeal space. Again, elevating the lateral pterygoid muscles, displacing it laterally and anteriorly. And here you see the very solid nature of the mass, and they get these central scars in the middle, so areas that enhance to a lesser degree. Now, this was another interesting patient that got referred in for facial swelling and temporomandibular joint pain, and we'll see this large cystic mass in the prestyloid parapharyngeal space, elevating the pterygoid musculature. You'll see here the displacement of the oropharynx, and again, another picture of the mass here. So this is an infected cyst. I stuck a needle in here. I got back about 10 cc's of pus. She went on a week of IV antibiotics and 6 weeks of oral antibiotics. This is what she looked like 3 months later, and this is what she looked like 6 months later. And you can see there's an underlying cyst. So this was one of those rare but atypical cysts sitting in the prestyloid compartment. Moving on to the masticator space. Right, so that sits anterior to the prestyloid parapharyngeal space. The investing fascia is the superficial layer of the deep cervical fascia. It extends, so it's very important. It extends from the inferior mandible all the way up to the attachments of the temporalis muscle. So it's extremely important to think about masticator space lesions, even those that sit over your temple and in the temporal fossa. It has cranial nerve 3, and remember, this is a conduit to get from foramen ovale to the skull base and the intracranial compartment, so always take a look at those skull base foramina. And these lesions tend to displace the prestyloid parapharyngeal fat posteriorly and medially. Okay, so now we're in the masticator space. What are the contents? Remember, the pathology is going to arise from the contents in that compartment. So we have the muscles of mastication, the medial and lateral pterygoid muscles, the masseter and temporalis muscles, the ascending ramus of the mandible, branches of the external carotid artery and veins, and the mandibular division of cranial nerve 5. So, masticator space, bone, ascending ramus, muscles of mastication. Here is our prestyloid parapharyngeal space. When lesions are large enough here, and when they occur medial to the mandible, they're going to displace the prestyloid parapharyngeal fat posteriorly and medially. So that's one of the things that you want to look for. The differential diagnosis of pathology in this compartment includes developmental lesions, so cavernous venous malformations, some people used to refer to them as hemangiomas, and venolymphatic malformations, which have both veno and lymphatic constituents, are very common in the masticator space. There's never a week I don't see them. They're often incidental findings. We have inflammatory pathology, typically odontogenic abscesses, delayed abscesses, and neoplastic processes. And when you're looking at neoplasms in the masticator space, don't get too wrapped up in figuring out what the histology is. What the clinician really wants to know is the mass benign or malignant, because it's going to determine how it's managed and if it's going to be followed, and is the mass coming from bone or is it coming from soft tissue? So here is your typical venous malformation. This one's in the masseter muscle sitting lateral to the ramus of the mandible. You'll see it's circumscribed. It's T2 hyperintense. It's got solid enhancement. It's a pretty characteristic appearance for a mass that's occurring within the muscle. And this was aspirated and was a venous malformation. Now, this is an abscess sitting high up in the masticator space. So this person had an odontogenic infection 3 weeks prior to this scan, went on IV antibiotics for 3 days in our emergency room, was sent home on oral antibiotics and came back with trismus, and 3 weeks later they had an abscess up in the masticator space. It's important to remember that you get retrograde reflux of all those organisms in your mouth back into the facial veins, which take you up into the skull base. Looking at neoplastic lesions, again, from bone, most commonly we have radiologically characteristic fibroosseous lesions like osteomas, osteoblastomas, and fibrous dysplasia. These are radiologically characteristic. By far the most common pathology that I see in the masticator space is the typical schwannoma, or occasionally a neurofibroma in somebody with neurofibromatosis type 1. But the vast majority of pathology I really see are venous malformations and nerve sheath tumors. Going into the malignant category, the most common pathology in a child is going to be a rhabdomyosarcoma, and the most common pathology in adults is going to be squamous cell carcinoma, lymphoma, and metastatic disease in the masticator space. And yes, we have an occasional spindle cell sarcoma in an adult, but again, the vast majority of pathology is going to be Mets, lymphoma, and squamous cell carcinoma. And again, remember, we're talking about lesions primarily to this space. The most common pathology in the masticator space is squamous cell carcinoma from the aerodigestive tract. So here's a very typical appearance of a schwannoma in the masticator space. You can see the lesion here, medial to the ramus of the mandible, displacing the lateral pterygoid muscle posteriorly and medially, and also the prestyloid fat. We can see the heterogeneous signal here on the T2 weighted image, again, splaying the lateral pterygoid muscle posteriorly as well as the prestyloid parapharyngeal fat, and the typical circumscribed and enhancing nature of the lesion. Here, this is an unfortunate case. This is a 17-year-old male that came to me on his birthday, and he couldn't open his mouth. And he has this large mass sitting in the masticator space here, and it looks like it's been growing for a while. You see some remodeling of the bone here. As we come here, we see the mass in the masticator space, and we see it growing towards the mandibular foramen. And when we look at the bone windows, very, very subtle, but you'll see some erosion of the back of the alveolus of the maxilla. You'll see some erosion of the bone anterior to the mandibular foramen, and if you look very closely, you'll see some lysis and some permeation of the pterygoid bone in plates, and this was a rhabdomyosarcoma. Again, under the age of 18, the most common malignancy is going to be a rhabdomyosarcoma. This is a patient, and you'll see a mass arising from the bone and the marrow. Here's the normal marrow on the other side. You'll see areas of cortical destruction, and you'll see an enhancing mass in the masticator space on both sides of the bone. This is almost always either metastasis or lymphoma. In this case, it happens to be lymphoma. Now, this is another little pearl I want to give you all. This is a patient that has a benign mixed tumor. You'll see a mass sitting along the anterior aspect of the masseter muscle. This is accessory parotid tissue. We all have that, little bits of it. And it's important to remember, you've got the zygomaticus muscle, the facial vein, and behind the facial vein you have the parotid duct. This is the facial vein, and you can see that there's going to be a little bit of rest of salivary tissue along that duct, and this is a benign mixed tumor coming from little accessory parotid tissue along the parotid duct. And the last thing I want to say about the masticator space is to please remember your temporal mandibular joint. This was read as a chondrosarcoma. This is not a chondrosarcoma. You'll see this large mass sitting in the masticator space, displacing the pterygoid muscles medially, right? Big mass here. And then you'll see all this chondroid material, okay? This is synovial chondromatosis, and it's important to remember that the The synovium of the temporomandibular joint comes all the way down the ascending ramus of the mandible, and in fact, it envelopes a large portion of the pterygoid musculature. So when you're looking in the masticator space, don't forget to think about other processes that affect the temporomandibular joint. This is another example of synovial chondromatosis. You'll see a big locular mass sitting in the temporomandibular joint underneath the articular eminence, and look at the profound mass effect sitting on the lateral pterygoid muscle that inserts up on the temporomandibular joint. Here you'll see the axial T2 weighted image. This is all the mass and the synovium going into the masticator space. And following contrast, you can see the enhancing inflammatory synovium, and all the filling defects are the chondroid material. Moving on to the post-styloid parapharyngeal space, or the carotid space, we have the carotid sheath. And the carotid sheath is made up of all layers of the deep cervical fascia. The sheath is complete below the carotid bifurcation in the neck. However, the sheath is often incomplete at the level of the oropharynx and the nasopharynx. It's important to remember that the carotid space extends from the jugular foramen all the way down to the aortic arch, and lesions in the carotid space will displace the internal carotid artery anteriorly, because most of the pathology arises either from the vessel or from nerves sitting behind the vessel. So if a mass is arising behind the internal carotid artery, the carotid artery is going to be displaced anteriorly. It's also important to remember that a lot of lesions in this location are radiologically characteristic. In other words, you know what the diagnosis is. So in the carotid space, we have the carotid artery, the internal jugular vein, cranial nerves 9, 10, 11, and 12, the cervical sympathetic plexus, and lymph nodes. So once you isolate a lesion into the carotid space, you say to yourself, what occurs there? Pathology arising from these structures. So the differential diagnosis of a carotid space mass. So first and foremost, we have the pseudomasses, jugular vein thrombosis, pseudoaneurysms of the internal carotid artery, most commonly secondary to carotid artery dissections. We have benign neoplasms, and by far the most common are paragangliomas and the schwannoma. You'll see an occasional meningioma there, but that's usually extension from an intracranial mass in the posterior fossa growing down through the jugular foramen and into the carotid space. And we have malignant neoplasms. Remember, the sheath above the carotid bifurcation at the oropharynx and nasopharynx is frequently incomplete, and so you can get direct extension or nodal metastases into the carotid space, but you can also get nodal metastases and pathologic nodes from lymphoma. So let's look at some examples. These are all cases that were referred to me for biopsy. You definitely don't want to stick this. You'll see a mass here, and the important thing is you're trying to figure out, is this in the pre-styloid space or is this in the carotid space? And I just couldn't find the normal common carotid artery. So this turned out to be a pseudoaneurysm. Here's another pseudoaneurysm. Again, hard to find the normal carotid artery. Always think about pseudoaneurysms. And this is another pseudoaneurysm coming from the carotid space. This is thrombosis of the internal jugular vein. You can see the normal vein here, carotid artery, and this is clot in the internal jugular vein, not to be mistaken for a mass. Here's another pseudoaneurysm. This was an aneurysm here in somebody that had bilateral internal carotid artery dissections. They occur most commonly at the skull base. And you'll see how large the carotid artery is here. And if you're astute, you'll see on the other side, it's very hard to find the carotid artery. That's because it's dissected. This is the CTA reconstruction showing the dissection and the pseudoaneurysm coming from the right internal carotid artery. Moving on to masses, so remember, schwannomas and paragangliomas. These masses arise from structures, nerves sitting behind the internal carotid artery. So you can see this is the carotid artery on the left. this internal carotid artery is displaced anteriorly because this schwannoma, T2 hyperintense and solidly enhancing, is arising from a nerve in the carotid space behind the vasculature. So this is a typical schwannoma. Here's another typical schwannoma, complex, solid, and cystic mass with displacement of the internal carotid artery. Anteriorly and medially, you can see the normal positioning of the carotid artery on the right. And this is a paraganglioma. Now you look at it and you might say, oh, this is coming from the prestyloid parapharyngeal space, but remember, you want to find the internal carotid artery. This is the internal carotid artery being displaced anteriorly. So it's a mass coming from the carotid space. If you had a lesion in the prestyloid parapharyngeal space, remember, those are going to displace the carotid artery posteriorly, right? Because they're anterior. So this is a mass from the carotid space, displacing the internal carotid artery anteriorly, and this is a paraganglioma. And what about this patient? This is a 34-year-old that had dysarthria and hoarseness. So the first thing you're going to see is they've got a vocal cord paralysis, right? Dilatation of the laryngeal ventricle, and you'll see medialization of the arytenoid. They've got an 11th nerve palsy, so 10 and 11. You'll see atrophy of the trapezius and this sternocleidoid mastoid muscle, and their 12th nerve is out. You'll see fatty replacement of the tongue. So now you're thinking 10, 11, 12. They're 9, the palate was also rotated. So I'm looking in the carotid sheath or the jugular frame, and that's what's going on in my head. And here is the classic paraganglioma. Here is a large vascular mass in the carotid space, displacing the internal carotid artery anteriorly, right? And you can see this is growing down directly into the jugular vein. Look how big this vein is. This vein is filled with neoplasm. And on the reconstructed image, this is dental artifact, but you can see the tumor in the vein, and here is the meniscus separating tumor from normal blood flow. So this is a paraganglioma. Moving on to the retropharynx. The retropharynx is a potential space. It's just a fat pad until you get pathology in it. And once you get pathology in it, you see the space very well. This is between the middle and deep layers of the cervical fascia, and this extends from your skull base to your mediastinum, and in fact, it can extend all the way down to the core of your diaphragm. So when you see pathology in the retropharynx, you need to follow it all the way down into the mediastinum to make sure you get the full extent of the pathology. The retropharynx sits anterior to your prevertebral musculature, and it sits posterior to the constrictor muscles of the pharynx. And very, very importantly, the pathology that arises there is usually medial to the carotid artery. So here's a sagittal image. You have your vertebral column, you have your prevertebral musculature, and in front of the prevertebral musculature and behind these constrictor muscles, you see a little fat pad coming down. That fat pad's your retropharynx between the prevertebral musculature and the constrictor system of your pharynx, and a diagram showing you the constrictor muscles in the mucosal surface here and the prevertebral muscles. And here is what happens. You begin to visualize the retropharyngeal space when you've got pathology in it. So, contents. The retropharyngeal space has a lot of mesenchymal tissue in it, but above the hyoid bone, it's got fat and lymph nodes, and below the hyoid bone, it's predominantly fat. There are some lymph nodes there, but the lymph nodes are much more abundant above the hyoid bone. So the differential diagnosis of pathology in the retropharynx is a collection or a mass, and the solid masses are almost always adenopathy, metastatic disease in the lymph nodes, and when it's not there and it's primary, you think of a spectrum of the uncommon mesenchymal tumors. So let's first look at collections in the retropharynx, abscesses, hematomas, and a spectrum of different effusions occur there related to pathology and surrounding tissues. So this is the typical abscess. You can see the retropharyngeal fluid. These often come from direct extension of a pharyngeal infection or from rupture of suppurative lymph nodes. But I just want to remind everybody in the very acute setting, Abscesses frequently look like solid masses, so you must look at these studies in the context of the clinical history. This is a very sick patient with fever and an elevated white count. This is what the acute abscess in the first 4 days actually looks like. This is what abscesses look like when they mature. So this is somebody you can see very sick, they're intubated, they've been on IV antibiotics and the abscess has not gone away. You can see the fluid in the retropharynx, right? You've got the constrictor system anteriorly and the prevertebral muscles posteriorly, and now we see eloquently the retropharyngeal compartment, again, constrictors in front and muscles behind. And don't forget to follow this all the way down into the mediastinum. You've got an abscess there. You've got to follow the inferior extent. And here again, a nice thing sitting in front of the vertebra and behind the constrictors, a nice demonstration. Now this is a drooling toddler, and on this radiograph you see marked widening of the prevertebral compartment. If you look, you'll see it's markedly enlarged and there's floccules of gas sitting in it. The most common pathology in a child in this location is a retropharyngeal abscess, and they normally come from foreign bodies that get impacted in the esophagus. So frequently what happens is, my kid did it too. You think your brilliant kid won't do it, but they do. They put coins in their mouth and jacks in their mouth. They swallow them, and you don't even know that they've swallowed them. And then these foreign bodies gets impacted in the esophagus. And what happens is it sits there, and maybe they'll have dysphagia. And then eventually what'll happen, if it doesn't move down the system, you'll get an inflammatory reaction and then an abscess. And if you look closely, we know this is in the esophagus because we can see the displacement of the trachea from the mass effect in the esophagus. So very important, once you see an abscess, get a chest x-ray, you'll usually find a foreign body there. This is what the patient looked like 6 months later. Now you see a stricture complicating the impacted foreign body. And it's very important to remember that these are typically delayed presentations. So they don't happen in the minute the kid swallows it. It's, weeks later when the infection develops. And the most common location for impaction is at the thoracic inlet, where you're going from skeletal to smooth muscle, 15% impact in the mid-esophagus and 15% in the lower. This is a missed perforation. So the nice demonstration of the retropharynx for you all. You can see the constrictor muscles here, and behind them and in front of the vertebra, you'll see the air coming down. Here's the prevertebral muscles. This is air. And again, a very nice demonstration of the retropharynx now that we've got pathology in it, air behind the pharyngeal constrictors and in front of the prevertebral muscles. This is a hematoma in a 72-year-old that had dysphagia after a fall. She was not on anticoagulants, but again, you can see this very, very large mass. It's sitting in front of the prevertebral muscles here, right? You got the constrictor, the internal carotid artery, right, sitting medial. And if you look, this is denser than this. And when you come here, you'll have the prevertebral muscles. So this is a retropharyngeal hematoma. This is active bleeding on the machine. So this patient is actively bleeding. She was emergently decompressed. This is an effusion in the retropharynx. You can see it doesn't have a rim-enhancing circumference to it. It conforms to the shape of the space that it's in. And very importantly, you can see the ascending pharyngeal arteries floating in the fluid. That's these structures here. If you look, there is massive lymphadenopathy in this patient that has B-cell lymphoma, and this is just a lymphatic infusion. And if you look more closely, you'll see pockets of lymphatic effusion in multiple compartments in the neck. They had originally called me to biopsy an abscess. I said, the fever's from the patient's lymphoma. I'm not putting a needle in anywhere. This is just a lymphatic effusion. And this is calcific tendinitis. This is another patient with prevertebral swelling. This is a retropharyngeal effusion related to hydroxyapatite crystal deposition, and you want to look very closely behind the anterior arch and below it, and you'll see these ossifications. This is hydroxyapatite. You don't need to do anything else. This is when they flex their head, it hurts. You give them Motrin, and it goes away. And the differential diagnosis of a solid mass in the retropharynx, adenopathy, inflammatory, which may go on to an abscess, we've just seen that, and malignant. And these most common metastases come from squamous cell cancer of the nasopharynx, squamous cell cancer then of the oropharynx, and thyroid cancer, the posterior lymphatic drain up to the retropharynx. You can see lymphoma there, and the major neoplasms are, come from mesenchymal tissue. This is a nice example of bilateral nodal metastases in the retropharynx. You can see the prevertebral fat in front of it. This is a patient with thyroid carcinoma, metastatic retropharyngeal node that was biopsied for and taken out robotically. This is a typical schwannoma, a circumscribed mass that you'll see here and solidly enhancing, again, behind the constrictor muscle, which is elevated in front of the prevertebral muscle and medial to the carotid artery. Nice there. And this is a rhabdomyoma of the retropharynx. So this was sort of an interesting case. I biopsied this. This was read as a thyroid gland, but it's not an enlarged thyroid gland. The thyroid gland is connected at the isthmus anterior to the airway. This thing is crossing the midline, so I knew it had to be coming from the retropharynx. You can see the prevertebral muscles behind it and the pharynx being elevated, and this was a rhabdomyoma that I actually biopsied very easily from the neck. This is an ectopic parathyroid adenoma, so occasionally you'll see one of these up here from the superior gland, and this is it confirmed on the Sestamibi study. Okay, this is a 31-year-old that came in with a palpable neck mass when he turned his head to the right. How many people think this is a paraganglioma? How many people think it's a schwannoma? Okay, so this is an important case. It got read as a paraganglioma, and it's important to remember that on CT you'll frequently see a tremendous amount of internal vascularity. It doesn't mean it's a paraganglioma, and in fact it's just vascularity. You don't see an avidly enhancing mass. If you're astute, you'll come down and you'll see, right, so we have the schwannoma. What space is this in? Prevertebral, prestyloid, carotid, or masticator? How many people say A? B? C? Okay, good. D. So the correct answer here is prevertebral, and this is really the answer. So if you look here, this is the patient's MRI. This is the paravertebral compartment. This is the prevertebral space. You've got the prevertebral muscle, and it goes down to the transverse process. This is the patient's tumor, elevating the prevertebral musculature, and if you're astute, you'll see it's coming from a neural foramen. This is the paraspinal space of the paravertebral compartment. That goes from the transverse process, and it goes down around the paraspinal musculature. Here is our patient. When he turns his head to the right, this thing becomes palpable. Here you can see the enlargement of the foramen, and again, scalloping of the vertebral body, and this is coming from the C3, C4 foramen. So this is a mass in the prevertebral paravertebral compartment here. Again, elevation of the prevertebral muscle. These are schwannomas. Most of them are sporadic. They come from sensory nerves, and they do not have malignant transformation. And our last case, so this is a 28-year-old immunocompromised patient with 3 weeks of neck pain, fever, and paraspinal mass. How many people think this is an abscess? How many people think it's a tumor? So what tumor do you think about in patients that are immunocompromised? Lymphoma, brilliant. So this is lymphoma. You'll see a necrotic mass here, and for the size of the mass, there's relatively little inflammation in the surrounding tissues, which you would expect with an abscess. If you're astute, you'll see there's a little component in the epidural compartment. This is B-cell lymphoma in the setting of PTLD. These occur after organ transplantation, ranging from benign lymphoid hyperplasia to lymphoma. This occurs months to years after transplant, and this usually mimics an abscess. So it's important to have this concept in your mind when you're thinking about abscesses. If the patient's immunocompromised, please remember lymphoma. The diagnosis is often delayed. The treatment is reduction of immunosuppression and radiation and/or chemo, and if it's untreated, it's usually fatal. These are EBV-induced lymphomas. If the EBV comes from the donor, it's an acute infection. If it comes from the recipient, it's reactivation. And seronegative transplant puts you at increased risk after transplant of getting it. It is directly related to immunosuppression, the degree of it, and how long you've been on it. And again, it's loss of cytotoxic T cells by EBV-driven unregulated proliferation. And our last case, just to show you, this is a tubercular abscess. This was a patient, I knew it wasn't bacterial because he was being followed for 8 months for TMJ symptoms. And then they scheduled me to biopsy him, and when I put him on the table, I saw this lesion on his arm. I'm like, what is that? I biopsied his arm, and that was tuberculosis, and he had been traveling overseas about a year earlier. So this is skull-base tuberculosis. Right on time. Thank you for your attention.